Hi, I'm going to show you today how to examine a knee, or certainly how I would examine a knee, because I think there's many different ways of doing that, as with many joints. Now, before I'll even go near the patient to examine them, I'd ask them to take their shoes and socks off, and I'd have a look at their shoes or their trainers to have a look, see if I could find any areas of wear and tear or anywhere that might be abnormal. So having a look at Lorna's trainer here, I can see that there's wear on the lateral heel margin, which is what I'd expect from a heel strike occurring laterally, for the foot then to slightly pronate and then for it to supinate again around the midfoot for launching off again, and indeed there's some wear there as well. But otherwise, looking at the trainer, that appears to be normal. I'd then have a look at the patient with them stood up. What I'd be wanting to have a look for is just exposing the area, having a look and comparing the two sides together to make sure I can't see any wasting of the quadriceps muscles, that I can't see anything grossly abnormal with the legs if I just turn you around. I'd then be comparing the hamstring muscles, ensuring that I can't see any wasting of those or any difference there. I then want to ask the patient to walk for me. So if I could just ask you just to walk backwards and forwards 2 or 3 times to the other side of the room and back. And here I'm working my way up from the feet upwards. So I'm having a look at what are the arches doing, what are the feet doing during walking, what gait have they got? Is there any abnormal movement in the hip or in the knee? Is there a painful gait or anything else that might give me some clues as to what might be going on? Okay, could I ask you to just jump up on there? Thank you. And if you lie yourself down. I think whenever we're examining anything, it's good to have a plan in mind as to breaking it down into chunks to make it easier to try and remember which pieces you're doing. So for an examination such as this, I'd be thinking of inspecting first of all. I'd then be thinking of palpating. I'd then want to look at a range of movement. And then I'd want to do special tests, either focusing directly on what I might be suspicious of, or more special tests in general. So I would want to ensure I've got good exposure. And again, what I'd want to do is compare the two sides together. For the purpose of this, I'm just going to be examining the right knee, but clearly there might be times when you would want to do the two knees together to compare. So having a look first of all, I've already looked stood up, but lying down, having a look laterally, and if I just ask you just to relax, brilliant, and I'm having a look just to make sure there's no fixed flexion deformity, and again, as I said earlier, I would be comparing both sides. I've been looking at the quadriceps, ensuring there was no wasting there. Does there appear to be any gross swelling around the knee at all? I can't, and shortly I'll show you how I would try and elicit any swelling. I then have a look at the calves, and then finally the feet, and all that looks to be normal. So having inspected, I'd now be thinking of palpating. And again, I would work with some order here, probably starting from the top going down. So what I would want to do first of all, with the leg extended, is to feel the quadriceps and ensure that there's no tenderness there. That doesn't feel sore, does it?
No.
I'd want to feel where the quadriceps insert into the patella. I'd then want to work around the medial border of the patella, and then the lateral border of the patella, and then the anterior surface of the patella to ensure that I can't find any areas of discomfort. I'd want to feel the patella tendon, if I was wondering about patella tendinopathy, and an insertion of the patella into the tibial tubercle, which one might find painful in something such as Osgood-Schlatter's disease. Now, if I wanted to ensure that there wasn't an effusion, I can milk it. I can milk the knee either downwards, trying to elicit any swelling being pushed into the knee joint, or equally I can milk the knee upwards. And that feels to be okay. Now, if I just ask you just to bend your knee, that's wonderful, thank you. This puts the quadriceps mechanism under some tension. And what I'm then able to do is just examine again the quadriceps, making sure there's no tenderness or no tenderness within the patella tendon or its insertion. With it flexed like this is how I find it easier to find the joint line. I would want to feel across the medial joint line, feeling for any areas of tenderness. Is that okay? And also across the lateral joint line. That's fine. And if we just pop your leg flat again, that's wonderful, thank you. I'd want to feel the medial condyle of the femur and then the lateral condyle of the femur. And if I was suspicious of something like a medial plica, some patients may have an embryonic residual of a plica in the synovium. In order to feel for that, I'll be wanting to feel between the medial border of the patella and the medial condyle, and feeling if I could roll anything there. Likewise, I may just want to flex the knee just to try and put some tension on there and ensure that that was okay. That's good. Now maybe just to roll over onto your front, please. Similar to what I've done anteriorly, I would want to do the same posteriorly. So I'd want to just feel the hamstrings. I'd want to feel where they insert into the ischial tuberosity to make sure I can't elicit any pain there, and also where they insert lower down and ensure that there's no tenderness there. That's wonderful. Now can I just get you to roll over, please, Lorna? So that's inspection and palpation done. What I want to do now is try and have a look at what range of movement there is. So in order to do this, what I'm going to do is actually, with your heel, can you touch your heel to your bottom or get your leg as far bent as you can? That's wonderful. And does that hurt at all, or is that okay?
It's fine.
That's okay, good. So what I can see there is there's a very good degree of flexion of the knee. And as I said earlier, I'd also be comparing the other side as well. So if we could just pop that flat, that's great, thank you. Sometimes with patellar instability, you're able to translate the patella laterally. So I'm pushing on the patella and just making sure that I'm not able to translate that too far laterally. And that's okay. That's fine. Good. I'm now going to want to do some tests for the menisci. And I'm going to start off initially doing the McMurray test. And in order to do that, we flex the knee. I'm going to do the medial meniscus first, so I place a finger along the medial joint line, and then under varying degrees of internal rotation and varus, and external rotation and varus, and valgus, I try and just make sure that I can't catch the meniscus or cause any pain. I then want to draw my attention to the lateral meniscus, and for that I put my thumb across the joint line there and I do similar movements. So I'm twisting and straightening, and that feels okay. Good. Another test for the menisci is something called the bounce home test. Before this, what I need you to do is completely relax your leg for me. And then I'm just very gently just going to bend the knee and then let it drop. I'm going to just do this, relax, and then drop. And that can be painful with the meniscal injury, and that's okay. Another test for a meniscal problem is the Apley's grind test. Can I just ask you to roll over onto your front again, please? And in order to test for this, essentially what I'm doing is trying to grind the menisci together. So if you just bend your knee for me to 90 degrees, that's wonderful. I then apply some downward pressure and then twist. And make sure that that's not painful and that feels to be okay. Okay, fine. Do you mind just rolling back over for me? So those would be my test for the menisci. Now I want to think about the ligaments. The medial collateral ligament, the lateral collateral ligament, the anterior cruciate ligament and the posterior cruciate ligaments. So thinking about the collateral ligaments first of all, I want to examine these both with the knee extended and also flexed. And I apply opposing forces for this to try and elicit any gaping in the ligament. So the medial ligament first of all, I'm going to apply a valgus strain on the lower leg. And then for the lateral one, the varus strain. Make sure that I can't see any gaping. And then what I want to do is just repeat that, just with the knee slightly flexed. And that feels to be okay. And I want to do some tests for the anterior and the posterior cruciate ligaments. The test that I would do for an anterior cruciate ligament would be Lachman's test. And in order to do this, we need the knee flexed to probably about 30 degrees. I then stabilise the femur with one hand whilst grasping the upper tibia with the other hand. And what I'm trying to do is a snapping movement anteriorly. And what I'm feeling for is an end point within the ligament. So you're feeling for where it finishes. And obviously if there's no end point, that's going to make you wonder about whether there is a rupture of that ligament. Another test that we can do for the, pop that just back, thank you, Lauren, for the anterior cruciate ligament is called the pivot shift test. Now that relies on the theory that the iliotibial band, which comes down here, is both an extensor of the knee and also flexor of the knee as well. And in order to check for that, what I want to do is put the knee on the lower leg onto some internal rotation, and then flex the knee. And then if the joint was to reduce doing that from the flexion of the iliotibial band, it would make me consider an anterior cruciate ligament problem. Next, posterior cruciate ligament. And in order to test for that, what I would want to do is if we just bend your knee up to about there, that's smashing. I'm putting my fingers on the femoral condyles and my thumb on the tibial plateau, and then I'm going to be pushing back like that on the tibial plateau, seeing how much movement and translation I have of the tibia posteriorly. The final test that I'd want to do is to try and elicit the difference between a posterior collateral ligament problem and also a posterolateral corner issue. And to do that, I just need you to flip over again, please. And here I'm going to compare both legs together. So if you lie with both legs together, that's wonderful. And initially, what I'm going to do is flex the knees to 30 degrees and then turn the feet outwards. Now, if one foot turned more than another outwards, for example, like that, that could be due to a posterior cruciate ligament problem or a posterolateral corner problem, and that's at 30 degrees. If I was to then flex the knees to 90 degrees and do the same, and that difference reduced itself so that both feet were the same, then I'd be thinking that this is a posterolateral corner problem. That's lovely. And can you just roll over again? So that's my examination of a knee, and I hope that's been helpful.